Okay. Yeah, hello guys. Good evening, all of you. And sorry for the delay because of the traffic jam. I got late, so kindly excuse me for that. So I hope I'm audible and visible. Please confirm once so that we can start. And sorry for the delay. Okay. So guys, I'm Dr. Dinesh and we are going to discuss MIQs, the most important question for FMG and NEET PG exam. NEET PG exam as well as FMG exam, for both these topics are very important, and these questions are very important. So let's see the questions. Let's start with the question. Question number 1. The question number 1 is, okay, so the question number 1 is, a patient with extensively drug resistant TB is started on a regimen which include the pretomanid. A very important question regarding the newer anti-tubercular drug. What is the best describe the pretomanid mechanism of action? So basically they have asked about the mechanism of action. Okay, so please take your I will take your doubts in the end. Please first focus on these MCQs. So let's see what are the MCQs. First is pretomanid regarding the newer anti-tubercular drug. You know the B-PAL-M regimen. B-PAL-M regimen. B for bedaquiline, pretomanid, L for linezolid, and M for moxifloxacin. These are the drugs. So we have the B-PAL regimen and we have the B-PAL-M regimen. So what is true? What is true regarding the mechanism of pretomanid? Options are, is it the ATP synthase inhibitor? Is it the folic acid synthesis inhibitor? RNA polymerase inhibitor? Or it is the NEETPG, which is active against tuberculosis? What is your correct answer, guys? What is your correct answer? So let me see your options. Okay, so no, many of you have given the wrong answer. That means you don't know about the newer anti-tubercular drug. Please read the topic newer anti-tubercular drug. So let's see, ATP synthase inhibitor. In ATP synthase inhibitor, the drug is bedaquiline. Folic acid synthesis inhibitor, this is not this newer anti-tubercular drug. In the folic acid synthesis inhibitor we have the sulfa drug. So the older drug, para-amino-salicylic acid, that was the anti-tubercular para-amino-salicylic acid, and that is the folic acid synthesis inhibitor. RNA polymerase inhibitor, no, that is rifampicin. Now you see the NEETPG active against tuberculosis. That is true regarding this. But additionally, other than NEETPG, it is the pretomanid, that is the NEETPG like drug which is active against tuberculosis. It is having the two mechanism. You can see the first is, it is nitric oxide generation in the anaerobic medium and it inhibit the respiration and energy production. But the second mechanism, most of you know about this second mechanism. It is inhibiting the mycolic acid synthesis. It is weakening the cell wall. So these are two mechanisms regarding the pretomanid. It is the drug used for the resistant tuberculosis, and don't forget the both mechanism. It is mycolic acid inhibitor as well as it is the NEETPG antibiotic which is acting via nitric oxide generation like metronidazole. So it is having these two mechanisms. Both these mechanisms are important. So that is true regarding the pretomanid drug. So what is the correct answer? The correct answer is option D. Okay. So now let's see the next question. A 35-year-old woman with body mass index of 38. So you can see the patient is obese. Is prescribed tirzepatide. What is unique about this agent? Is it selective SGLT1 inhibitor in pharmac? Don't forget the mechanism of the drugs. Don't forget the important adverse effect. You know the use, right? Uses are everybody's knowing because you know the use in medicine. But in pharmacology, mechanism of action and adverse effect. So is it SGLT1? Is it GLP1? Is it dual GLP1 and GIP, or it inhibit the lipase? What is true about tirzepatide? तो बच्चे दिस tirzepatide is important. ये तीर बहुत important है. This tirzepatide is the important anti-obesity drug. It is the anti-obesity also. So it is the anti-diabetic drug which is having anti-obesity property. It is approved. It is subcutaneous injection. If you see the option, is it selective SGLT1 inhibitor? No, no, bhai. It is not having the effect on SGLT1. SGLT1, SGLT2, these are sodium glucose transporter. SGLT1 transporter, that is there in the gut. SGLT2, that is in the PCT, kidney. So we have the ORS which is acting on SGLT1, and we have the SGLT2 inhibitor gliflozin. So this drug is not related to SGLT, not related to sodium glucose transport. It acts on GLP1. It is acting on GLP1, but not only GLP1. In GLP1 we have the drugs like glutide, semaglutide, liraglutide, exenatide. So these are natide or glutide. The important drug nowadays we are using the semaglutide. I think every bacha knows about the semaglutide because celebrity has hit this drug. This semaglutide is hit because of the celebrities, because many celebrities are promoting this drug unnecessarily. You know, the Ozempic, that is semaglutide. Semaglutide is the drug which is orally approved. Semaglutide is the drug which is orally approved GLP1, and that is important drug for obesity. But don't forget कि the faults जो हैं ये, these faults will be loose faults. तो जल्दी बूढ़ा लगेगा. The person will look older than the age. So that is because of these faults. You know, these faults, wrinkles will be there because of the semaglutide. Just think if buccal fat buccal fat lost because of this, the person will feel the older than the age. So that is the disadvantage of this drug. Then you can see this drug is dual GLP1 and GIP1. Yes, that is the correct answer. GLP1 is glucagon like peptide, and GIP is glucose dependent insulinotropic peptide. Glucose dependent insulinotropic peptide. So it is GLP1 as well as GIP, and wonderful mechanism. You know, by using these two mechanism, it is wonderful drug on the obesity, tirzepatide, and the risk of hypoglycemia is less. Why the risk of hypoglycemia is less? Because this is glucose dependent mechanism. So because of this, you will see the hypoglycemia risk is less. It's a wonderful drug. Can you tell me the name of the drug which inhibits the lipase? The name of the drug which inhibits the lipase is orlistat. That is oral gastric lipase inhibitor, orlistat. And because of orlistat, fecal incontinence is there. Fecal incontinence. So that's why orlistat is one of the disadvantages. It is fecal incontinence. So it is used, but we have to be careful regarding the fecal incontinence. So the correct answer of this is option C. It is the dual. It has been approved. It has been approved for diabetes as well as for the weight reduction. Okay, don't forget to revise the anti-obesity. Okay, let's see the next question. A 50-year-old man with a history of diabetes present with a painful erythematosus lesion on the thighs with purulent discharge, and the culture is showing the MRSA, methicillin resistant Staphylococcus aureus. What is the most appropriate oral antibiotic for this patient? So patient of MRSA, typical history, diabetic patient who are having the painful erythematous lesion. So these are Staphylococcus lesions, and it is a purulent. So that is confirmative Staphylococcus, but by culture also we have proved it is MRSA. So guys, what is the most appropriate oral antibiotic for this? Is it vancomycin, dicloxacin, linezolid, or ceftriaxone? Remember, it is about the MRSA. In MRSA, all the penicillin, cephalosporin except fifth generation cephalosporin, all the beta lactams are not effective. So beta lactams are not effective except fifth generation cephalosporin, ceftaroline, ceftabiprole. These are fifth generation, they are effective. So beta lactams are not effective except fifth generation cephalosporin. Ceftriaxone, that is the third generation cephalosporin, not effective. Dicloxacin, that is the penicillin, not effective. Now you have the option vanco and linezolid. So what is the correct answer? What is the correct answer, bacho? Because vanco is parenteral drug. You know the red man syndrome. you know the red man syndrome, you know the ototoxicity due to vancomycin. Don't forget the red man syndrome, ototoxicity, nephrotoxicity with the vancomycin. Linezolid is the drug, wonderful drug which is inhibiting the protein synthesis. Linezolid inhibits the initiation process. It is binding to 23S of ribosome. 23S. It is inhibiting the protein synthesis. It's a wonderful drug for MRSA, VRSA, as well as the vancomycin resistant enterococci. It is a wonderful drug, and don't forget, it's a MAO inhibitor. Even though mainly it is causing bone marrow suppression, but don't forget the MAO inhibition. Because of MAO inhibition, you will see MAO inhibition causing cheese reactions due to MAO inhibitor. Serotonin syndrome due to MAO inhibition. So the name of the drug is linezolid. That is oral drug. Yes, bache. Anshita ji, in pseudomembranous enterocolitis, we can use vancomycin orally. Because that will be the topical effect. That is the topical effect. It is not going to absorb. The oral bioavailability is very poor because it is highly ionized compound, right? Okay. Yes, definitely. The squanger, linezolid binds to 50S, definitely 23S of 50S ribosome, right? That is absolutely correct. Okay, guys. So what is the correct answer? This is the correct answer, linezolid, right? In riluzole is saying if pneumonia, lungs, in daptomycin. No. Daptomycin is not effective. Daptomycin in lungs infection not effective because daptomycin will be inactivated by the surfactant. So we use the linezolid only. Daptomycin is effective for systemic infection, septic infection, but not because of the pneumonia, because of the surfactant. Okay, bache. So the answer will be linezolid. Don't forget the drugs which are orally used against the MRSA is cotrimoxazole, that is trimethoprim sulfamethoxazole, doxycycline, linezolid, clindamycin. These are the best drug, and out of these linezolid is very, very, very important, right? So okay. So this is about the question number 3. Now let's see the question number 4. A 26-year-old woman with postpartum depression. Nowadays depression is very common psychiatric disorder, most common psychiatric disorder. Integration with the psychiatry, psychopharmacology, very important, frequently asked topics. Recently approved drug zuranolone, postpartum depression after delivery. The recently approved drug zuranolone. What is true regarding this drug? So what is this drug? Is it serotonin receptor acting drug? Is it fast acting NMDA antagonist? Is it GABA receptor modulator? Or it is NMDA inhibitor? What is correct regarding this drug? Again, very important drug, integrated with the psychiatry. You should know about this drug, postpartum depression. So bache, zuranolone, the first important thing is it is the oral drug. We have the brixanolone. Brixanolone is the parenteral drug, that is the IV drip. So we have these two drugs for postpartum depression. These two drugs is specifically used for moderate to severe postpartum depression. In mild postpartum depression, still SSRIs are used. The first drug in mild depression is SSRI, but in severe cases we use these newer drugs. Okay, yes, the brixanolone is the IV drip and zuranolone is the oral drug. Both these drugs are acting on the one of the neurosteroid, that is allopregnanolone. These are allopregnanolone. So these drugs are basically targeting the GABA receptor. These are the drugs which target the GABA receptor, and it is the oral drug. So option C is absolutely correct. Now can you tell me which 5-HT1A receptor targeting the depression? So we use the buspirone, zapirone like drugs. These are used mainly for anxiety. Fast acting NMDA antagonist, NMDA. So in fast acting NMDA inhibitor, NMDA antagonist, we have the S-ketamine, that is approved for depression. S-ketamine nasal spray, that is approved for depression. S-ketamine, ketamine or S-ketamine. So S-ketamine nasal spray is available. So that is the drug for depression. Nowadays we use S-ketamine in the depression. The nasal spray approved for this. Okay, so this drug is GABA A receptor modulator, approved for postpartum depression, bachcho. Very important. So this is the correct answer. Okay, let's see the next question. And remember that course of the total duration of zuranolone is 14 days. Okay, let's see the next question. A 58-year-old man present with the sudden onset joint pain in a big toe. In big toe there is sudden onset joint pain. arthrocentosis is showing the negatively birefringent crystals. He has CKD stage 3, chronic kidney disease stage 3. What is the best acute treatment? What is the best acute treatment? What is the correct answer, bachcho? The patient of, it is a patient of acute gout. It is a patient of acute gout. What is the best treatment for this patient, bachcho? What is the best treatment? Is it indomethacin? Is it allopurinol? Is it colchicine? Is it febuxostat? So if you ask me, sir, the question is about acute, so rule out these two options, because allopurinol and febuxostat, these are used in chronic gout. These are used in chronic gout. Allopurinol is the drug which is used in chronic gout, but don't forget the HLA sensitivity. And in the febuxostat, it is the good drug for CKD patients, but that is for chronic, not for acute condition. The hypersensitivity risk is less with the febuxostat. But the question is about the acute. Indomethacin. Indomethacin is one of the NSAID. NSAIDs are not to be used in CKD stage 3 in the kidney patients. You will never use indomethacin. So in the severe gout, in the acute severe gout, colchicine is the best drug. Even though it is not 100% risk-free drug, but in these patients, this is the best selection of the drug. So colchicine is the best drug in these patients. Remember, colchicine is inhibiting the the metaphase. It is the M phase inhibitor usually, but why it is effective in gout patient? Because it is inhibiting the chemotaxis. It is inhibiting the chemotaxis. That's why it is used in the gout patient. Chemotaxis inhibitor, and the commonest side effect of colchicine is diarrhea. The commonest side effect is diarrhea. The risky side effect is bone marrow suppression, secondary infection. But out of these, in CKD patient, you can use it colchicine. So the correct answer will be CKD. So colchicine we are using. If required, you can adjust the dose, and that is the best drug. Okay guys, let's see the next question. Very important, clinically integrated question. A 32-year-old man with chest pain is found to have ST elevation in the lead V1 to V4. He has a history of cocaine use. Very commonly you will see in emergency after parties in the night from the clubs, the patients are reaching to hospital with the chest pain, diagnosed as in acute, 32-year young patient having the chest pain, cocaine abusers, it could be heart attack. He has given aspirin and nitrate. Which medication should be avoided? Which medication you will avoid in this patient? Morphine, atorvastatin, clopidogrel, or metoprolol? A very important question. Let me check your knowledge, bache. What you will not give? Very good guys. Some of you have given absolutely correct answer. Yes. SKG, allopurinol is having the HLA sensitivity, skin reactions. Okay, so focus on this question now. Yes. If the patient is having chest pain after cocaine use, cocaine is the drug which is NRI. It is a sodium channel blocker, because it is the NRI, norepinephrine reuptake inhibitor. So it increases the norepinephrine action. It increases the norepinephrine effect. It's a sympathomimetic. That's why there is risk of heart attack. It's a sodium channel blocker. That's why it is used for local anesthesia. So here, why the heart attack is there? The heart attack is because of the norepinephrine reuptake inhibitor. It increases the noradrenaline. It means it's a sympathetic stimulation. If you give beta blocker, what about the alpha? Unnecessary alpha action will be there, because cocaine is having the effect on beta, alpha both. You have blocked the beta, heart rate will be down. But now unopposed alpha action, alpha causing vasoconstriction, and this vasoconstriction can increase the risk of progression of the MI due to vasoconstriction, or it can increase the blood pressure. So it is having the paradoxical negative effect on the patients. So out of these, which drug is not given? Metoprolol we never use in cocaine for this purpose. Which drug we use? We use the clonidine. Clonidine is central sympatholytic. We can use the clonidine. You can use the morphine. Morphine is a sedative drug. You can sedate the patient. You can decrease the heart rate by using the morphine. You can use the atorvastatin, there is no harm of using the statins. You can use the clopidogrel, there is no harm using the anti platelet drug. But metoprolol, beta blocker, just imagine beta blocker is given, then unopposed alpha action, vasoconstriction, and that is not safe in this patient. This is the reason we never use beta blocker in these patients. Okay, so that is the correct answer. Metoprolol, unopposed alpha stimulation leads to sudden vasospasm, can worsen the symptoms of MI. Okay, so this is the reason, bachcho. Okay guys, okay, let's see the next question. A 75-year-old woman with atrial fibrillation and creatinine clearance of 20 ml per minute needs anticoagulation. She has no history of bleeding or fall. Which is the most appropriate oral anticoagulant in this patient? Tell me, bachcho. 74-year-old woman with atrial fibrillation and creatinine clearance of 20 ml per minute needs anticoagulation. She has no history of bleeding or fall. Batao bachcho, what is the correct answer? Rivaroxaban, dabigatran, warfarin or enoxaparin? The question is about oral. So please rule out one option which is not oral first. Always read the option carefully. No oral, so no enoxaparin. Enoxaparin is parenteral. So one option is out. Now we have to see A, B and C. So creatinine clearance is 20 ml per minute only. So creatinine clearance is low. It means this patient of kidney patient. This patient is kidney patient. Kidney functions are low. GFR is low. Creatinine clearance is low. So now tell me about which is the most appropriate oral drug. Which drug you will use out of these? Out of the oral drug, which is option? Yes, tell me, bachcho. So can we use rivaroxaban, which is the 10th A inhibitor? Can we use dabigatran, which is the 2nd A inhibitor? Can we use warfarin, that is the conventional older, newer, conventional anticoagulant? Or you can say the vitamin K oxidoreductase inhibitor. So what is the correct answer out of these which is safe in the kidney patient? So out of these, the safe in the kidney patient is warfarin. Rivaroxaban, dabigatran is not safe in kidney patient. If low creatinine clearance, warfarin is safest option. You know, warfarin is depending on the liver, it is metabolized in the liver. So warfarin is the safest in these patients. So don't forget the warfarin. Warfarin is the preferred anticoagulant in the patient with severe renal impairment. All direct oral anticoagulant except one drug. Don't forget the apixaban. That's why apixaban is most commonly used oral anticoagulant nowadays. This is the reason. Warfarin is safest in end-stage renal disease, but out of the newer drug you can use the apixaban. Don't forget the apixaban is safe out of the newer oral anticoagulant. Don't forget that. Okay. So what is the correct answer? The answer is C. बेटे D कैसे हो सकता है? Enoxaparin is parenteral. So maybe by mistake the option D has been given as answer, but the correct answer will be warfarin. There is no doubt in that, right? So please correct it. Okay, understood? This is the reason we always say read the explanation carefully. Read the attend these sessions carefully. Okay, next question. A 75-year-old man present with palpitation and shortness of breath. ECG is saying the atrial fibrillation and rapid ventricular response. The heart rate is 138 beats per minute. He has a history of CHF with preserved ejection fraction. EF is preserved, not reduced. History of CHF is there, but reduced ejection fraction is not there. EF is maintained. Heart rate is high. Atrial fibrillation. What is the best initial rate control agent in this patient? What is the best initial rate control in this patient? Options are digoxin, metoprolol, diltiazem or ivabradine. Okay. Okay. Anshita is saying, sir, in CSF with atrial fibrillation we give digoxin. No. Read the question carefully, bache. Read the question carefully. Read the question carefully. Digoxin is the drug which is inotrope. Digoxin is the drug inotrope. Why we use inotrope in this patient? This patient is having the preserved ejection fraction. Why unnecessarily give the inotrope? The purpose should be in this patient to control the heart rate with reduced mortality rate. The purpose should be control the heart rate with purpose of reduced mortality rate. That is the purpose. So which drug are used for reducing the mortality in heart failure patient? To reduce the mortality sorry guys, sorry, excuse me, to reduce the mortality in CHF patient. That should be the aim always, and simultaneously in this patient the heart rate is very high. So what are the drugs? Told you many times. B for beta blockers, A for ARBs, ACE inhibitors, ARNI, or the potassium sparing diuretics. These are the drugs we use: beta blocker, ARNI, ARBs, ACE, and potassium sparing diuretic. Okay, these are the drugs we use. Now the question is, the first drug out of these to control the heart rate is definitely beta blocker. So in CHF patient, if the preserved EF, if the EF is preserved, why to give digoxin? Digoxin is the inotrope. So in this patient there is no role of inotrope. So we use metoprolol, yes. Diltiazem. Why to use diltiazem? Diltiazem is a calcium channel blocker. There is risk of reducing the EF with the diltiazem. There is risk of reducing the EF with the diltiazem. With metoprolol, this risk is not seen, because we have seen these cardioselective beta blockers. They are very good drug in CHF. If you start with low dose, they maintain the EF. They don't reduce the EF. So in this patient, beta blocker with a wonderful drug. Ivabradine. Ivabradine is also causing bradycardia, but never a first line drug. After beta blocker, if still the heart rate is high, definitely you can add the ivabradine. Definitely you can add, because बच्चे calcium channel blockers are having the risk of reducing the EF. Calcium channel blocker is negative inotrope. Even though beta blocker is negative inotrope, but beta blockers are having less risk of negative inotropic mechanism, especially the drug metoprolol succinate. There are three important drugs. One is bisoprolol. The another drug is carvedilol, and one is metoprolol succinate. These three drugs are only drugs which are approved for heart failure patient. If the reduced ejection fraction is not there, they are definitely practically very important drug, because they do not reduce the EF. Okay. The Muhammad is asking, sir, if reduced EF, then answer is diltiazem. No. If reduced EF, then answer will be digoxin. Then only we use the digoxin in these patients. Otherwise, we don't use beta blocker. We don't use calcium channel blocker in this patient. Okay. So answer will be metoprolol. Read these explanation. उसमें सब लिखा हुआ है. Okay, guys. Next question. A 60-year-old woman with cardiovascular disease is intolerant to statins due to myopathy. Obviously, in myopathy, it is intolerant to statin. LDL remains elevated. LDL is still high. You can see our target is less than 100. The target of LDL should be less than 100. It is 140. So you consider inclisiran, bachcho, important drug. Dyslipidemia. Don't forget to revise the drugs for dyslipidemia before going for your main exam. What is the mechanism of inclisiran? What is the mechanism? Every bachcha should know the inclisiran. Inclisiran is the drug. Let me tell you, sir, which drug inhibit the ATP citrate lyase. That is the bempedoic acid. That is also new drug that is inhibiting the ATP citrate lyase. By this, what happens? You inhibit the HMG-CoA reductase enzyme metabolism. If HMG-CoA reductase enzyme metabolism will be inhibited, HMG level will be high. Now inhibit the cholesterol absorption, that is AGT-MIB. Inhibiting the cholesterol absorption, that is inhibiting the Niemann-Pick's 1C1 like 1. Monoclonal antibody against PCSK9 inhibitor, these are like evolocumab, alirocumab. So these are QMABs. And this drug cRNA, see the name, inclisiran, CRAN. So it is cRNA that block the PCSK9 synthesis. So this mechanism is similar to evolocumab, but this is inclisiran. Little bit different. You can see it is the cRNA that is blocking the PCSK9 synthesis. PCSK9 synthesis less. PCSK9 is basically important for LDL metabolism. If PCSK will be less, LDL receptor metabolism will be less. More LDL receptor, more LDL uptake. तो PCSK9 block, that means more LDL receptor. More LDL receptor means more LDL uptake from the plasma to the tissues like liver, and that's why the plasma LDL will be decreased. Okay, so this is the important, that is reversible. Okay, so the correct answer will be CRNA. This is important, and you can see it is very long. It is given twice yearly, it means 6 monthly doses in inclisiran, but थोड़ा costly है, थोड़ा नहीं, ठीक ठाक costly है. अगर if you go with the brand, then you will get the cost of injection is around 20-30,000. Okay, let's see the next question. A 54-year-old woman with schizophrenia developed the resting tremors, rigidity, bradykinesia 2 months after starting risperidone. Risperidone is the drug which is antipsychotic, atypical antipsychotic, but it is having the D2 blocking property. So there is risk of resting tremors, rigidity, bradykinesia. These are extrapyramidal symptoms. These are extrapyramidal symptoms. What is the most appropriate? What is the most appropriate treatment? Options are propranolol, benzatropine, carbidopa, tetrabenazine. Every bachcha should know about it. Every bachcha should know, because risperidone is the drug out of the atypical antipsychotic drug which is having D2 blockade property, have the risk of extrapyramidal symptoms, also having the risk of Parkinsonism, also having the risk of hyperprolactinemia. So these risks are there. So if there is risk, then what you will give to treat these extrapyramidal symptoms, to treat the drug induced extrapyramidal symptoms or drug induced Parkinsonism? What is the drug? In the drug induced Parkinsonism, we use the central anticholinergics. We use the central anticholinergics. Central anticholinergic. So what is the correct answer out of these? We never use carbidopa, levodopa in these patients, because already the dopamine receptor is blocked. Tetrabenazine is the VMAT inhibitor, VMAT2 inhibitor. These are dopamine depleters. These are dopamine depleters. Dopamine depleters are not for this purpose. Benzatropine or propanol. Propanol is used in akathisia. That is used for akathisia treatment, but benzatropine is one of the central anticholinergic. That is benzatropine, benzhexol, trihexyphenidyl. All these drugs are same group drug, and these are used for drug induced Parkinsonism. Don't forget it. Okay guys, so this is the correct answer. Anticholinergics like benzatropine or benzhexol. Let's see the next question. Very important question from the respiratory medicine. A 35-year-old woman, 35-year-old woman with severe eosinophilic asthma. Very important. Eosinophilic asthma or eosinophilia patient who are having asthma has frequent exacerbations despite inhalational corticosteroids and long-acting bronchodilator, long-acting beta-2 agonist. The eosinophil count is 480 per microliter. Which of the following is the best biological therapy for this? Nowadays there is role of biological therapies. So what do you think guys? Omalizumab, lecanemab, mepolizumab or mycophenolate mofetil? So definitely not this. It is IMP dehydrogenase enzyme inhibitor. This IMP dehydrogenase enzyme inhibitor is immunosuppressant. This is immunosuppressant. Immunosuppressant used for organ transplantation. It is not nephrotoxic. That is the benefit of this drug. Out of this drug, you can see omalizumab. This Mali is IgE inhibitor. That is for IgE. Lecanemab, that is for nervous system, that is targeting the amyloid plaques. That is the amyloid inhibitor, that is for dementia patient. That is for dementia patient. And mepolizumab, this is interleukin 5 inhibitor. We have the three important drugs: mepolizumab, raclizumab, benralizumab. These are interleukin 5 inhibitor, and that is approved for eosinophilic asthma, severe eosinophilic asthma as biological therapy. Don't forget the three drugs. Don't forget these three drugs: mepolizumab, raclizumab and benralizumab. Don't forget. Can any bachcha tell me which is the interleukin 4 or interleukin 13 inhibitor? Any bachcha, which is interleukin 4 or 13 inhibitor? Mainly 4. Mainly targeting the 4, having some effect on 13. What is the name of this drug? Any bachcha inhibiting the interleukin 4. So the name of the drug is starting with D. because D is 4 number. Yes, dupilumab. Okay, dupilumab. Siddhant is asking why not A. Bache, that is not for eosinophilic asthma. Right, that is approved for allergic asthma but not for eosinophilic asthma. Only biological therapy which is approved for this is interleukin 5 inhibitor. Okay, dupilumab, bache, dupilumab. Very good, guys, very good. Okay, let's see the next question, your favorite question from the depression. A 29-year-old woman on fluoxetine, you know the fluoxetine is SSRI, for depression, wants to switch to phenelgin due to lack of response. Phenelgin is one of the MAO inhibitor. MAO A. So, how long should you wait? Before starting the phenelgin, बच्चों? कितने दिन wait करें? Options are 28 days, 3 days, 7 days, 14 days. What do you think, guys? What do you think? Fluoxetine, every bacha should know the fluoxetine. Fluoxetine is the longest drug, very longer half-life because of the norfluoxetine. Fluoxetine is going to change in the norfluoxetine, very long half-life. You know, up to 2 weeks you will see the effect of this drug. So very long acting drug. You want to, give the phenelgin. Phenelgin is the MAO inhibitor with SSRI. MAO inhibitor with SSRI. There is risk of serotonin syndrome. Serotonin syndrome risk is there. So our purpose is to avoid this risk of serotonin syndrome. So definitely we'll wait for the drug to, fluoxetine to be eliminated from the body. So you can see it is very half-life. Norfluoxetine, the half-life is around 2 weeks. It will take many half-lives, 4 to 5 half-lives for, elimination. So you can see if you give the fluoxetine, now you want to switch, wait for the fluoxetine effect. Wait. So the effect of fluoxetine, you will see the effect of fluoxetine will be continued. At least you will see around 8 to 10 weeks there will be effect, but almost 75%, more than 75% drug is eliminated if you wait for 2 weeks. 2 half-life. So you will see around 28 days most of the drug is out. The risk of serotonin syndrome is not there, and that's why we wait for 1 month. To switch from the SSRIs to MAO inhibitor. So wait for 28 days. If you will give before that, and there is a risk of serotonin syndrome. Okay, bache. So what is the correct answer? You can see the correct answer is fluoxetine. The very long half-life, around 2 weeks, I told you. So bache, we have to wait for at least washout period, at least 4 weeks. Definitely more than that, but at least 4 weeks. Okay, let's see the next question. My favorite question. So 45-year-old man with epilepsy is taking phenytoin. His plasma drug level are increasing disproportionately to his dose. When you increase the dose, the plasma level is increasing disproportionately. Which pharmacokinetic property explain this? Nehaji, definitely 8 weeks, but we don't wait for that much time practically. Always remember, the examiners are smart, they are clinician as well. They don't give this type of irrational options. So Nehaji, you will not get the option of 8 weeks because we don't wait practically for 8 weeks. If you wait for 8 weeks, then what happens? The patient will have the risk of depression. Right? Depression will worsen. So we wait for 1 month. Okay, guys. Okay. So why disproportionately the plasma level is increasing? Because in the first order kinetic, it is not increasing disproportionately. So the phenytoin from the first order kinetic to in the high dose, it is converting to 0 order kinetic, and suddenly you will see the plasma level will increase disproportionately because of the slow elimination in the 0 order kinetic. First order kinetic, the elimination depends on the fraction, but in 0 order kinetic, the elimination rate is constant. So you will see the elimination rate is constant, so it will be slow, and that's why it is suddenly disproportionately increase. So the answer will be because it is converted from first to 0 order, and this is also called as pseudo 0 order kinetic. Can you tell me the name of a drug which is having true zero order kinetic. Bachcho, the name of the drug following the true zero order kinetic. Any bachcho, can you tell me the name? So it is not because of the this plasma protein binding or extraction. It is because of the zero order kinetic. Don't forget the drugs follows the zero order kinetic. So in general pharmac, this is one of the important question. The drugs follow zero order kinetic, saturation kinetic, or therapeutic index, narrow therapeutic index. These are, those response curve, very important. Okay. Definitely most of you, all of you have given the correct answer. It is the alcohol. Alcohol is acha sathi hai. So alcohol is true. So a patient on dabigatran develops GI bleeding. What is the most specific antidote? Nowadays the question from the antidote very commonly asked. Dabigatran is the oral. Dabigatran is the oral, and you can see tran, it is the thrombin. So oral second A inhibitor. It is the oral thrombin inhibitor. Oral second A inhibitor. What is the antidote? Remember, the most common risk associated with dabigatran is GI bleed. The most common risk is GI bleed. What is the most specific antidote? So remember, dabigatran, dabi means daba ke, orally daru pilo. So it is the idarucizumab. It is the idarucizumab. Very important. Vitamin K is for warfarin. And dexa, see the name dexa, antidote for dexa. It is the antidote for 10th A inhibitor. Like apixaban, rivaroxaban. Tranexamic acid, that is antifibrinolytic Trenexa. So idarucizumab. And nowadays we have one seraparentag, that is non-specific antidote. Can be used for all. Non-specific antidote. It can be used for both type of these drugs. Okay, very good guys, very good. Both badhiya, clap for all of you. Okay, let's see the next question. In the next question number 15. Okay, don't worry, we started 15 minutes late, so we will definitely do more 15 minutes I will take. Okay, 42-year-old women with bipolar disorder on lithium. Without lithium the exam is not over. So lithium is admitted for dehydration and vomiting. Lithium is commonly causing polyuria. So there is dehydration, there is vomiting. She become confused, ataxic and tremulous. Tremors are very common. Confusion, ataxia, these are the sign of lithium toxicity. Which factor most probably precipitated these symptoms? So what do you think guys? Why lithium toxicity? This is the question related to drug interactions. Which drug causing the interactions commonly? Increase the GFR is not going to cause the toxicity. Increase the GFR means loss of lithium. So that is definitely not going for toxicity. Okay. Liver is not related to lithium metabolism. Lithium is not going to metabolize. Lithium is going to excrete as it is. Use of acetaminophen. Acetaminophen is not as much nephrotoxic. It is mainly hepatotoxic. Nephrotoxicity is very less. It is there but less nephrotoxicity. What about the hydrochlorothiazide? This is the drug which is a diuretic. And diuretics causing the drug interactions. This diuretics will cause the drug interaction with the lithium. What happens? Diuretics causing loss of sodium. Now this extra sodium, because they inhibit the sodium reabsorption, this extra sodium will reach to collecting duct. In collecting duct we have the epithelial sodium channel. This epithelial sodium channel will take the sodium and release the potassium. But in this case lithium is misidentified as sodium, and the collecting duct sodium epithelial channels will take the lithium instead of sodium, and that causes the lithium toxicity, lithium retention. So that's why use of thiazides, more lithium absorption through these channels, ENaC channels, more toxicity. The best treatment for this lithium toxicity is amiloride, that is the epithelial sodium channel blocker. Amiloride will be given for treating this lithium toxicity. So that is the correct answer. In this case definitely the level is more than 2 milliequivalent per deciliter, because it is tremors, confusion, ataxia. So definitely the level is toxic. More than 2 will show the symptoms. More than 1.5 is toxic, because usual is 0.5 to 1.2. but more than 1.5 is toxic. So definitely if more than 2, then it means there will be symptoms, and more than 5 we need the dialysis. Okay, let's see the next question. A 48-year-old man with alcohol use disorder, one of the common substance abuse, has abstained from drinking for the 3 weeks. 3 weeks से पिया नहीं है भाई साहब. He is motivated to stay sober and ask for help preventing the relapse. He has been motivated, but now to prevent the relapse, the help is asked. What is the best drug? बच्चों? Which drug is best? Options are disulfiram, option is naltrexone, option is lorazepam, option is bupropion. Let me check your knowledge regarding the alcohol. Regarding alcohol, all बच्चे are having the good knowledge. Very good बच्चे, very good. बहुत ही बढ़िया. So guys, already alcohol use disorder, he is abstained from drinking since last 3 weeks. So it means at present there is no withdrawal symptoms. There is no withdrawal, you can see. He is motivated to stay sober and ask for help preventing the relapse. The drug which is going to prevent the relapse. If you want to prevent the risk of relapse, the best drug out of these is naltrexone. Lorazepam is the drug for withdrawal symptoms. Lorazepam is the best drug to de-addict, to prevent or treat this withdrawal. Bupropion is for anti-smoking. Disulfiram is aversion therapy. That is not a first choice. That is used if after naltrexone or these drugs, the last option we use is the disulfiram, because that is risky. There is risk of flashing reaction. So naltrexone we use. Naltrexone is the opioid receptor antagonist that is used for preventing the risk of relapse. The another drug we use is the acamprosate. Mainly we use these 2 drugs. Acamprosate is NMDA blocker. But out of these, the best option is definitely naltrexone, because naltrexone is the first choice in these cases. Right? Okay, great. Palak has explained everything about this question. Very good, bachche. So this is about the... So we use the disulfiram. You can see only second line drug, not a first line drug, because of its aversive effect. That's why we don't prefer, because patient will not want to use this disulfiram. Okay, let's see the question number 17. Some new question, some new drug, important especially for NEET PG guys. Very important drug, very important. 52-year-old women with metastatic triple negative breast cancer. These questions are specifically for, my NEET PG fellows. Very important question for you guys. Metastatic triple negative breast cancer. My favorite topic nowadays, anti-cancer, antibiotics, autocoids. They are asking the question from these topics. So these 3 questions are dedicated for you from these topics. Metastatic triple negative breast cancer, but having TROP2 positive refractory triple negative breast cancer. TROP2 positive refractory TNBC. What is the best drug to treat this case? So let's see the option. First is olaparib. It is the PARP inhibitor. Let's see. It is the PARP inhibitor. What is pembrolizumab? That is one of the immune checkpoint inhibitor. Ciclib, that is the CDK inhibitor. Cyclic dependent kinase CDK4/6. That is cyclic dependent kinase inhibitor. Sacituzumab govitecan, a new important drug, and that is TROP2 inhibitor. Now I hope you got the answer, because by this you get everything. So guys, remember first thing, olaparib is not for triple negative refractory cases, guys. If you see the options, you can see when we use the olaparib. See carefully, first see this table. If BRCA mutation is there, we use these PARP inhibitors. BRCA mutation, not for TROP2. AKT pathway is under clinical trial, not important for us. But TROP2, if TROP2, then we use the sacituzumab. Very important drug, sacituzumab, for the TROP2. See, BRCA has been asked. Regarding breast cancer, they are commonly asking the question. They have asked all the drugs from the breast cancer treatment. The only drug remaining is the TROP2 inhibitor. That's why I am saying for NEET PG this is very important. In every exam they have asked about the question from the breast cancer, drug from the breast cancer. So they have asked about the BRCA1, they have asked about the Ciclips, they have asked about all the drugs, but they have not asked about the sacituzumab. So it is the drug TROP2 target refractory triple negative breast cancer, BRCA negative, HER2 negative, BRCA2 negative, all the negative. So BRCA mutation, PARIP for BRCA mutation, TROP2 for this purpose. So it is the drug, it's a TROP2 targeting antibody. It is new drug targeting SN38 and used in refractory cases of triple negative breast carcinoma. Don't forget this. Beta, pharmac is not difficult. These are the drugs which you will use in whichever branch you will do the PG. You will use these drugs, because when you will be a clinician, all these drugs will be the first choice. Important drug. Breast cancer, every bacha, every doctor should know the treatment, every surgeon should know the treatment of breast cancer. So out of these, what is the correct answer? Sacituzumab is the correct answer. Okay, so important, don't forget. Okay guys, don't worry, that's why we have done the question. Take your mistakes as a positive feedback. If you have done the question and the answer is wrong, now take it like a feedback. Now next time whenever the question will come in the main exam, I will definitely give the correct answer. So that should be the intention when you solve these MCQs. This is just preliminary things. The main focus is main exam. So in that exam you should not do the wrong. So nothing to showing these sad faces if your question is wrong in this test. This is just to realize ki it is definitely you will do the wrong, then in main exam you will do the right thing. Okay, so don't worry. Okay, next question. 60-year-old man with metastatic colon cancer, again for my bacha NEET PG, this is very important, is found to have a KRAS mutation, KRAS G12C mutation. What is the novel drug used for this purpose? What is the novel drug for KRAS mutation? Because again all the question have been asked except this KRAS G20C mutation. So definitely the number is this only. Okay, don't worry. Sometime maybe the person is in hurry and that has given the wrong answer, but this is the correct answer. Whatever we are discussing right now, that is the correct answer. So in this you can easily rule out cetuximab and panitumumab. You can rule out these two. These are EGFR inhibitor for EGFR mutation. Cetuxi and panitu. Remember Sita Pani. So cetuximab, panitumumab. Now we have the osimertinib and sotorasib. So in this patient you give the rasib or martinib. Osimertinib have been asked. Only sotorasib is remaining. Okay. Yes guys. Yes. So this is the correct answer. Sotorasib. So you can see, don't forget about the osimertinib. In last time the question, the osimertinib was the question. Osimertinib is also EGFR tyrosine kinase inhibitor. It is important for T790M resistance mutation in the non-small cell lung cancer. It is not used for colorectal cancer. It is the drug used for lung cancer. Osimertinib, EGFR tyrosine kinase inhibitor, EGFR mutant, non-small cell lung cancer, osimertinib. Don't forget T790M resistance mutation. But KRAS inhibitor, this drug, sotorasib, that is the drug approved for non-small cell lung cancer as well as it is used in the colon cancer, and it is for KRAS G12C mutation. So don't forget sotorasib. Okay, so this is important guys. So let's see the second last question from the recent topics, because in medias nowadays this topic is very hit. So I always advise whatever things are happening in the world, always focus on those topics. Don't ignore those topics. A 4-month-old girl is diagnosed with spine muscle atrophy, SMA type 1. You know the orphan drug for SMA atrophy, onasemnozin injection. You know this injection is 16 crores injection. 16 crore injection. So what is the purpose of this gene? So it is a gene therapy. Yes. In the name only. So you can see, if you see some new questions, Don't just forget, don't ignore the question, just see the name, you will find something, it is the zine which is for replacing SMN1. So that is zine therapy for SMA1. Don't forget onasemnozin abaparvovec, it is the drug. Don't forget this very important question, especially the pediatric people. It is available with this brand name but not in India, Zolgensma. And the cost of this injection is 16 crore. So just imagine 15-16 crore अपने पास तो भैया पूरी जिंदगी में नहीं होना. So that's why not easily available, import duties and taxes and all, very difficult, but mostly they are life saving. Without this the child is not surviving. So this is important. Okay, so let's see this question now. Last question, simple question. A 35-year-old man present with 10-year history of recurrent, just lengthy question but very simple question. History of recurrent migraine characterized by pulsatile unilateral headache, photophobia, nausea. So basically giving the history of migraine. He typically has 16, right? He typically has 16 attack. Okay, so no worries, I don't know about the politics. Okay, so he typically has 16 attacks per month which last for more than 5 to 6 hours and uses sumatriptan during acute episodes which offer partially relief due to frequent attack. His neurologist advised the prophylaxis. Without migraine the exam is not over for my FMG bacha as well, NEET PG as well as FMG bacha. This is very important. Don't forget, the students who are preparing for NEET PG as well as FMG, without migraine the exam is not over. From the autocoids, migraine, rheumatoid arthritis, and this gout. Don't forget, out of these questions are frequently asking. So what is the most likely mechanism of action of this drug in migraine prophylaxis? Right? Oh. They have not given the complete question. Okay, so let me tell you about the drug. This drug is given scalp injection. We give this scalp injection every 3 months. So which drug is this? Now tell me the mechanism of action. Sorry, the question is not complete. So sorry guys, excuse me. So tell me guys, what is the answer now? Scalp injection, 3 monthly injection. What is the most likely mechanism? So inhibition of voltage gated sodium channel? No. Sodium channel, voltage gated? No. Is it blockade of CGRP receptor? These are G-pens. Blockade of CGRP, G-pens. And G-pens are not for this purpose. G-pens, also G-pen, Ubro G-pen, we use these, but they are in acute, not for prophylaxis. Okay. The drug is scalp injection given every 3 months. 3 to 6 months, mostly 3 months we repeat. So inhibition of presynaptic acetylcholine release, activation of serotonin 5-HT. So this is lasmiditan. And that is also for acute purpose. So what is the drug? Option C. That is onabotulinum toxin. The intention is just to tell you about this toxin. So it is the onabotulinum toxin A, and this toxin we use as Botox injection in the scalp. Scalp injection we give, and it is for prophylaxis, a wonderful drug in these type of patient. You can see he has 16 attacks per month. When the patient is having 16 attacks per month and which last for more than 5 to 6 hours, always think about this. It is the Botox injection. So these are the drugs for migraine prophylaxis. Don't forget about this botulinum. Botox for migraine prophylaxis. More than 15 headaches and at least 8 migraine days per month. Duration of headache you can see more than 4 hours. Then you give this. It is the drug which is inhibiting the release of acetylcholine at the presynaptic level. By inhibiting the acetylcholine release, it decreases the neuromuscular inhibit the neuromuscular junctions, right? Okay, so every 12 weeks you can see we are using. Most important is we give for 31 standardized sites in the frontal, temporal, occipital area, and very effective drug. So it is the drug, last option. So this is all, and this is a bonus question. This is a bonus question, just bonus question for my dear students. This is the bonus question. This is the last question. 20 questions were given in the test. This is a bonus question for you guys. Sir, it's a new thing in the CAD, and triglyceride level is 280. So definitely the triglyceride is high. Despite the statin therapy, icosapent ethyl we are using nowadays. The clinician prescribing this drug. What is the proven clinical benefit of this drug? What is the proven clinical benefit of this drug? Icosapent ethyl. What is the proven benefit? Nowadays, instead of fish oil, we prescribe this. Instead of fish oil, in the past we used to say fish oil, but nowadays we give this, and this is very effective for some patients who are having the high triglyceride level. The question is giving everything, GAD patient with high triglyceride. So the purpose of this is to reduce the triglycerides level, as well as it reduce the mortality. In the first question you can see no effect on CV outcome. No, it is having the effect. It has been proved now. HDL increase with reduced stroke. No, it is not having role in HDL. It is not having role in LDL. It is having role in triglycerides, and it has been proved to decrease the mortality. So don't forget this name, icosapent ethyl. So that's all my bacho. I hope I justified this 1 hour by all these questions from the all topics of pharmacology I have covered. I wish you all good luck. If you got more than 10-12 correct answer, then definitely you are doing the good work. Revise these topics, revise pharmacology, and don't forget to revise these topics especially which we have selected, right? So definitely, so that's all. Thank you. I wish you all good luck for your exam. We are preparing for NEET PG, FMGE. I wish you all good luck, and after exam don't forget to follow me. After exam don't forget to follow me to get the updates in pharmacology. This is my Instagram ID, dr_Dinesh Yadav. You can follow me and you can ask me your personal doubts as well. So thank you guys, thank you. I hope you enjoyed. I enjoyed with all your comments, all your answers. बढ़िया. Yes, थोड़ा फार्मेक daily करते रहो, right? Do some topics daily. Topic wise revision is best. Instead of doing the complete pharmacology, instead of doing the complete subject, I ask all the students to revise the topics daily, right? Topic wise revision is the best way to revise and to avoid the frustration. So that's all बच्चे लोग. Thank you, bye bye, take care, good night, namaskar, धन्यवाद.